Welcome to the deep dive. We're tackling a really critical area for your medical understanding, especially, if the MSRA is on your horizon. Ascending cholangitis. Consider this your streamlined, high-impact session to really lock down the essentials.
Absolutely. We've sort of boiled down the core knowledge from our sources to give you exactly what you need for effective revision.
Right.
Our mission in this deep dive is to properly explore ascending cholangitis, what it is, what causes it, who's at higher risk.
How it develops.
Exactly. How it develops, what else it might look like, who gets it, how it presents, how we find it, manage it.
The outlook, complications.
Yeah.
The whole picture.
The whole picture,
Right.
yeah. And hopefully make it stick.
Okay, let's dive right in then. Ascending cholangitis, also called acute cholangitis.
Yeah.
Fundamentally, it's a bacterial infection in the bile ducts. So what usually kicks things off?
Well, the crucial first step is usually some kind of obstruction within the bile duct.
Okay.
Like, imagine a blockage stopping the normal flow of bile. And the most common reason for that blockage, gallstones.
Gallstones again.
Yep. Given how common gallstone disease is, it just makes sense they're the main culprit.
Right.
So when this bile flow is blocked or slowed right down, bacteria, which normally hang out in the intestines, can actually travel up into the bile ducts.
And cause infection there.
Precisely. Leading to infection and inflammation. It's really important to remember that bile itself is normally sterile.
So it's the bacteria getting in that's the problem.
That's the root of it, yeah.
So gallstones are the main trigger. But are there other ways the bile ducts can get blocked?
Definitely. Gallstones are number one, but you can also get blockages from strictures.
Like narrowings.
Exactly. Narrowings of the ducts, or tumors, maybe pressing on the ducts from the outside or growing inside.
Okay.
Sometimes complications from biliary procedures, like an ERCP, that can sometimes trigger it.
Right, the scope procedure.
Yeah. And even though less common, certain parasitic infections can cause obstruction.
Got it. So obstruction is the key. Now, who's more likely to actually develop this? What are the risk factors we should look out for?
Good question. The big ones are kind of obviously having gallstones in the first place.
Makes sense.
Also, any abnormalities or strictures already in the biliary tract, having a biliary stent put in can increase risk.
Okay.
Previous biliary surgery, obviously. And having stones specifically in the common bile duct that's cholelithiasis.
Right, stones in the main pipe.
Exactly. And importantly, if someone's had cholangitis before, they're more likely to get it again.
That figures. So the blockage happens, bacteria get in.
Yeah.
How does that actually progress to the full-blown condition, the pathophysiology?
So it follows a sequence. First, you get the obstruction. Bile can't flow properly. It sort of backs up, stagnates.
Okay.
The stagnation is like an open invitation for bacteria from the gut to ascend, to climb up into the bile ducts.
Right.
Once they're there, they multiply. That causes the infection, and the body responds with inflammation in the walls of the bile ducts.
And that's what causes the symptoms and potential problems.
That's it. Blockage, bacterial infection, inflammation, symptoms, and complications.
Understood. Simple sequence when you break it down.
Ooh.
Now, when a patient comes in looking unwell, maybe with some of these symptoms, what else could be going on? What's the differential diagnosis?
Yeah, this is super important. The differential is broad because the symptoms can overlap. You've got to think about other biliary things first, like acute cholecystitis.
Gallbladder inflammation.
Right, or cholelithiasis without the infection yet. Then there's acute pancreatitis, hepatitis.
Okay, other upper abdominal stuff.
Exactly. And other serious things like diverticular disease or mesenteric ischemia, lack of blood flow to the gut.
Right.
Even systemic infections that might present similarly, like other causes of septic shock, or conditions like cirrhosis, liver failure. Liver abscess is another one. And don't forget things like acute appendicitis, maybe a perforated peptic ulcer, or even pyelonephrosis, a kidney infection. It's a long list.
That really highlights why you need a proper workup. Yeah. So how common is this condition? And who tends to get it?
It's relatively uncommon overall, but when it happens, it's serious, an emergency.
Right.
Some studies suggest up to 9% of people admitted for gallstone issues actually have acute cholangitis.
That's quite significant.
It is. And post-ERCP, the risk is around 1%. Demographically, it seems more prevalent in fair-skinned people of Northern European descent, also Hispanics, Native Americans, and Pima Indians.
Interesting. Male versus female.
About equal, actually. No strong gender bias. The median age when it presents is typically between 50 and 60.
Okay.
And this is important. In about 10 to 30% of cases, the underlying cause isn't stones, but actually a malignancy causing the obstruction.
That's a crucial point to remember.
Yeah.
Okay, let's get into the clinical picture. How does someone with ascending cholangitis actually look? What are the signs and symptoms?
The classic picture involves three things. Abdominal pain, usually sharp in the upper right quadrant.
RUQ pain.
Yep. Jaundice, the yellow skin and eyes. And a fever, often with chills.
That's Charcot's Triad, right?
Exactly. Charcot's Triad, it's a key one for exams. A good way to remember it is FJR, fever, jaundice, right upper quadrant pain.
FGR, got it.
But critically, only about 20 to 50% of patients actually present with all three classic signs.
Ah, okay, so not everyone reads the textbook.
Pretty much. So beyond the triad, you'll often see raised inflammatory markers on blood tests, CRP, white cells.
It makes sense with infection.
Yeah. And we grade the severity mild, stage 1, moderate, stage 2, severe, stage 3. Severe means there's organ dysfunction involved.
Okay.
And in the really sick patients, maybe 10–20%, they can develop Reynolds Pentad.
Which adds two more things to Charcot's.
Exactly. It's Charcot's Triad plus septic shock, so low blood pressure and altered mental status, like confusion.
So FGR plus altered mental state and hypotension.
You got it. Think Reynolds, FJR plus AMS plus hypotension. Other things you might see are pale stools, acolic stools, and itching, pruritus.
Oh.
And, as we said, a history of gallstones, CBD stones, recent procedures, even things like HIV/AIDS, should raise your suspicion.
Right. Context matters.
Absolutely. And if someone keeps getting attacks, you strongly suspect untreated stones are the underlying issue. On exam, you're looking for that fever, RUQ tenderness, jaundice, maybe the mental changes and low BP if it's severe, plus tachycardia.
Okay, so FJR and Reynolds Pentad are really key flags. How do we actually confirm the diagnosis then? What investigations do we use?
Right, investigations. We start with bloods, definitely looking at liver function tests,
Yeah.
LFT, so bilirubin, liver enzymes, and infection markers. Full blood count for white cells, CRP.
Standard stuff for infection and liver issues.
Exactly. Then imaging is crucial. Often the first step is an ultrasound.
Why ultrasound first?
It's non-invasive, readily available, and pretty good at seeing gallstones and checking if the bile ducts are dilated, which suggests blockage.
Okay.
We might also use a CT scan, which can sometimes see calcified stones better, or an MRI, particularly MRCP. Magnetic resonance cholangiopancreatography. It's really good at visualizing the bile ducts non-invasively. Endoscopic ultrasound is another option too.
But what's the gold standard?
The gold standard for both diagnosis and treatment is ERCP.
The endoscopic procedure again?
Yeah. Endoscopic retrograde cholangiopancreatography. It lets you directly see the ducts, take samples, remove stones, place stents. It's diagnostic and therapeutic.
Very useful. Are there specific criteria, like a checklist, for diagnosis?
Yes. Generally, you need at least 2 out of 3 things. First, clinical evidence, so fever, chills, jaundice, abdominal pain.
Okay.
Second, lab evidence raised white cells, high CRP, abnormal LFTs.
Right.
And third, imaging evidence seeing biliary dilation or other hepatobiliary abnormalities on ultrasound, CT, or MRI, MRCP.
2 out of 3. Clinical, labs, imaging. Got it.
So we've confirmed it's ascending cholangitis. What's the management plan?
Okay, management. First thing, this is a medical emergency, needs immediate action.
Initial steps are about stabilizing the patient. So fluid resuscitation, IV fluids, correcting any clotting problems if they exist, and starting broad-spectrum antibiotics right away to hit the likely bacteria.
Okay, stabilize, fluids, antibiotics. What are the core principles after that?
3 main things. Continue the antibiotic therapy, achieve biliary decompression.
Meaning drain the blocked bile.
Exactly. Relieve that pressure and obstruction. That's usually done endoscopically with ERCP, removing stones or stenting, or sometimes percutaneously through the skin under imaging guidance.
Okay.
And the third principle is addressing the underlying cause, usually getting rid of the gallstones, often by removing the gallbladder later on, cholecystectomy, or maybe biliary bypass surgery in complex cases.
And does the approach change based on how sick the patient is? You mentioned severity stages.
Absolutely. It's staged. Stage I, mild cholangitis, mostly antibiotics, maybe ELCP later if needed for stones. Stage 2, moderate, needs early drainage. That might be ERCP or sometimes temporary drainage with something like a T-tube placed surgically or percutaneously. Then definitive surgery like cholecystectomy once they're stable.
And stage 3, the severe cases.
Stage 3 involves organ failure. So priority 1 is organ support ICU care maybe. then urgent biliary drainage is critical to control the source of infection.
Right, get that pressure off immediately.
Immediately. Definitive treatment of the cause comes later, once the patient is improving. So if they're in shock, confused, have organ injuries, or DIC, emergency drainage is essential.
And sepsis management follows standard protocols.
Yep, absolutely. Standard sepsis bundles and guidelines apply.
That makes sense. Stabilize, drain, antibiotics, then deal with the cause, tailoring urgency to severity. It's a typical outlook, the prognosis.
Generally, if it's caught and treated promptly and properly, the prognosis is actually quite good.
That's reassuring.
It is. But mortality does vary. It's higher in older patients or those with lots of other health problems.
Understandable.
A key factor for a better outcome is early biliary drainage, especially via ERCP. Getting that blockage relieved quickly makes a big difference.
Are there specific things that suggest a poorer prognosis?
Yes, there are several factors linked to worse outcomes. Things like low albumin levels, a prolonged prothrombin time suggesting liver isn't working well, very high bilirubin levels, high fever, very high white cell count.
Oh.
Also advanced age, low blood pressure on presentation, very high CRP, and needing antibiotics for a really long time. These are all flags for a potentially tougher course.
So again, acting fast is key. Finally, what can go wrong if things aren't managed well or if the case is very severe? What are the complications?
Complications can be serious, unfortunately. Sepsis is a major one, obviously stemming from the infection.
Right.
You can get liver abscesses forming. Over time, biliary strictures can develop from the inflammation. Pancreatitis can be triggered, and in the worst cases, multiple organ failure.
That sounds severe.
It can be. Other potential severe complications include outright liver failure, bacteria getting into the bloodstream bacteremia leading to gram-negative sepsis and septic shock. Acute kidney injury is common.
Oh.
You can also see dysfunction across multiple systems. Cardiovascular, neurological, respiratory, renal, hepatic, hematological issues like DIC. Bleeding complications can occur, maybe from the drainage procedures, fistulae, bile leaks.
It really underlines the seriousness.
And one really nasty one is reflux of heavily infected bile causing overwhelming sepsis. So yeah, the potential complications are significant.
Okay, that really paints a clear picture of why this is an emergency. So let's quickly summarize this deep dive for MSRA revision. Ascending cholangitis, serious bacterial infection, usually due to bile duct blockage, most often gallstones. Key things to recognize: Charcot's Triad fever, Jaundice, RUQ pain, remember FJR?
Right.
And in sicker patients, Reynolds Pentad, adding altered mental state and hypotension.
FJR plus AMS plus hypotension.
Yeah. Understanding the risks, the need for prompt diagnosis, urgent biliary drainage, and antibiotics are absolutely crucial for management.
Couldn't agree more. Getting those basics definition, causes, risks, presentation management really solid is essential. Hopefully this deep dive has given you a clear, memorable framework for your revision.
Absolutely. And for even more fantastic resources to nail that exam, definitely check out passthemsra.com.
And don't forget freemsra.com for loads of free questions and guides too.
Great resources. Thanks for joining us on this deep dive.